what I'd like to do is just briefly introduce our three panelists who will make remarks about their engagement with the work in Haiti and their understanding of infectious disease outbreaks. And the first is Pablo Mayrgundter.
Close enough.
Close enough. Who, as Sonia said, was involved as part of the Google .org crisis response team that did some of the creative mapping of the pandemic in Haiti. Pablo's been with Google for almost a decade, and it's a really interesting subculture of our techies who are now trying to use the power of the telecommunications revolution to actually contribute to the public health revolution. He was trained at Carnegie Mellon, one of the great tech schools that is cranking out these kind of people, and Pablo will speak first. Our second speaker will be Dr. Annie Sparrow, who, and you obviously heard my appreciation for multidisciplinary scientists. She's both a clinical practitioner, but also has a lot of public health expertise and particularly work in the most distressed areas through humanitarian crisis work and combat zones. She's currently an associate professor and deputy director of the Human Rights Program in the Department of Global Health right here, next door almost, at the Icahn School of Medicine at Mount Sinai, where she teaches on human rights and humanitarian responses. She's been quite an active voice in trying to elucidate some of the responsibilities and accountabilities for not only for polio and the reemergence of polio, particularly in Syria. And our third presenter will be Dr. Jonathan Epstein. Again, cross-trained. He's both a vet from the Grafton School of Tufts, close to where I teach, but he's trained in epidemiology, the core analytic tool of the public health trade, and is currently the Vice President of Conservation Medicine at EcoHealth Alliance, which is a non-governmental organization based here in New York that is trying to bring greater awareness to the emergence of infectious disease and the role of zoonotic transmission and the importance of what in the public health world is called now the One Health concept of trying to bring together veterinary medicine, clinical medicine, public health sciences, social and economic aspects together. He's also very well published in premier journals, and he's, I think, going to talk about how we're going to see more of this emergent viral disease leading to greater pandemics. So I'm going to ask each of you to take about 7 or 8 minutes to make your remarks, and then we'll cycle back and then open it up for question and answer. So Pablo?
Hello. All right. Hi, everyone. Thanks, John. So I'm not a health professional, but I work with data a lot. Doctors Without Borders asked us to come down and help them during the cholera outbreak, particularly around mapping geodata, getting things that were in spreadsheets and being passed around emails onto maps to allow for analysis for better decisions. So I think my role here is to pick up on the thread of how data makes a difference in these responses. So first, let me give you a little background of what a response looks like from the perspective of MSF, Doctors Without Borders. Their main issues they're looking at when they get there is what are they doing with tracking the outbreak. They want to know where the hot spots are and potentially what the cause is. Next, they would like to know what their capacity is, how many beds do they have and where. In the situation in Haiti, there was many agencies there besides just Doctors Without Borders, many hundreds of NGOs, the US military, Haitian government. And there was a pretty strong question of what's called in the disaster response space 3W, or who's doing what where. And I'll get back to that in a minute, but that's a key kind of goal when they're starting up operations and trying to organize work. It's just a basic understanding of what's going on and how to cooperate. They also have significant just internal logistics problems with their own staff and also their operations. So they have doctors coming in and cycling off after some amount of time working. And it was very harsh conditions, like people were being worked around the clock until they couldn't work anymore, and then they'd go out on the next plane and there'd be fresh folks coming in. Not only are the people doing the work kind of important resources, but also moving people around. There's not great roads, there's poor infrastructure. So like just having trucks with gas and water and food for people who are working turns into a major problem. So there are both doctors and also logistics coordinators who kind of form the backbone of the response. When they contacted us and asked us for help mapping, we said, oh, we've got these great tools online, you should use them. And then they politely told us to come try using them down in Haiti, where there is actually pretty good internet connectivity, but it's not as good as it is here, and there's a lot of kind of twiddly stuff that you have to do as a data person to get things to work right. What they really need is reliable ergonomic tools that they can use quickly. So we went down, I stopped by Best Buy, bought a bunch of GPS units that they had on the shelf, and also some pool chlorine testing kits. We decided that of all the things that we could help them with, kind of getting two main data sets onto a map side by side would be the most useful, and that's how clean the water is and where are the new cases being reported, and was there a causal link between the two. So we went down, much like the John Snow's work that Sonia was talking about, to try to make this map. We trained folks who knew the local area, how to use the GPS units and get waypoints, which is pretty straightforward. It just takes an hour, and how to test with the chlorine testing kit. And then sent them out, and over a week they started reporting in water cleanliness ratings at different places. At the same time, we worked with the folks who were collecting clinic rolls to get the street names that people were reporting where they lived before they showed up to the clinic, also into the same spreadsheet so that we could compare the two side by side. We put the two together on a map. They were already doing something like this, but one thing you might take for granted that's not true there is street names don't always agree, and reports of what place names are frequently either confused or there are multiple names for places. So one of the resources we had, which really enables a new situation like this, is the satellite imagery that you're familiar with. We can actually cut that out and put it on a disk in a way that you don't need to be connected to the internet. And so we could have locals sit there with the two spreadsheets of all the street names or reported place names and actually try their best guess of like when the person said this, what did they mean, and putting these all together on a map. This was kind of the key fusion point of the data that allowed us to generate the maps that hadn't been done before. People had done kind of one-off attempts, but without good GPS waypoint information and also kind of a dedicated high-resolution aerial map of the location, it was hard to piece it all together. But once that was there, people sat for many hours looking at sky pictures to do this, but we got the map together. This map was brought to, it was very obvious at this point that there was about a 1 to 2 day lag from where dirty water was reported to the next cholera outbreak. So it was then put into use immediately. The hypothesis had been suspected, but the acuteness of it was not so obvious until we started seeing the maps. That started to be put into practice or use for allocating staff and resources by MSF immediately, and then also was brought to the UN cluster system to advocate a much more stronger response by the state water agency, who had not basically taken care of the problem of dirty water. So I was there in the meeting where everything was kind of like, oh, we're making progress, and then MSF holds up the maps and shows the actual outbreaks happening very clearly with something as easy to measure as the chlorine amount in some water. And this basically changed the strategic reaction by the WASH cluster, the water providing agency, the government and MSF, into coordinated action to make sure that pumps had fuel to always be operating so that they wouldn't, I guess when pumps turn off, the back pressure from water allows cholera to come back from sewage or develop in the water supply. Always have pumps with gasoline, and also have like a response team available to go from the government whenever the water quality started dipping lower, to have people kind of on standby to go take care of that problem. And that was the very kind of concrete difference that seeing, just like the Jon Snow example, seeing all this data on a map together in a very chaotic place changed the way the response could proceed. Thanks.
Annie?
Thanks, John. I was fascinated when I first listened to Sonia and understood the historical dimensions of cholera. For me as a clinician, then over the last 15 years where I worked in places like Afghanistan, and where I actually caught cholera, by the way, I'm a cholera survivor, and Somalia and Zimbabwe, what I'm really struck as that these are not so much often diseases of poverty, but diseases of human rights violations. And that's really what I wanted to bring to the panel tonight, because as Zach pointed out, public health is absolutely critical, and we see that right now. It's very clear, I think, to everybody with the rise of Ebola. And how to understand these diseases, cholera, polio, Ebola, HIV, which is the original epidemic that perfectly illustrated how it was fueled by human rights violations. But how to understand them through human rights violations, and that actually helps our response. Because these are not just diseases of poverty. There are some diseases like malaria which are kind of indifferent to war or disaster, they appear whenever. And there are other diseases that are quite special. So when I talk about what understanding through health outcomes, for me working in Syria, which is the worst humanitarian crisis at the moment, I was originally started out trying to measure human suffering through health outcomes, because it was the only tangible way I could imagine of measuring human suffering. And very quickly I stumbled across the fact that not only was polio reappearing in Syria after 18 years, but that Syria had had a cholera epidemic in 2009, which had been very successfully hushed up by the Syrian government. It's coincident at the same time that I was in Zimbabwe working on the cholera epidemic there. But we all knew about that epidemic. No one knew about it in Syria. It was hushed up, and it was a result of lack of public health, lack of clean water, lack of sanitation, lack of sewage, withholding of public health, and this political preferencing of where public health would be built up in this country. That was deeply interesting to me, because when talking about human rights and the right to health, a great deal of the right to health is actually contingent upon the right to clean water. And then you put a war on top of that, and you attack civilians, you destroy hospitals, you criminalize doctors, you withhold the chlorine, and you really compound those things. So that's where that's how I look at them. And I look at them too thinking, cholera's been around for several hundred years, but we think it's forgotten disease. So we don't care about it very much in the US, the same way we didn't really care about Ebola until about 6 weeks ago. And so my colleagues who worked in Goma after the Rwandan genocide of 1994, there was a cholera epidemic there, and it was badly treated, which caused an excess probably of tens or even hundreds of thousands of deaths, because we didn't know how to treat it with oral rehydration. It was badly treated, and all the fear meant that I wish I had remembered to bring the slides of bulldozers bulldozing the dead bodies into mass graves, which is a terrible thing to do. People think that they're protecting other people from the spread of cholera, but that way you're denying people the right to bury their loved ones properly, which is also what's happening in West Africa today. And people really want to be able to have funerals, bury their dead properly, and if you know how to manage a disease, you take a lot of the fear out of it. The stigma attached to these diseases is terrible, so that, first of all, people don't even necessarily want to admit when if they might have something such as polio in particular. And refugees get blamed a lot. Thomas Duncan was blamed for bringing Ebola to America. And yet, I feel like, and actually President Shirley Johnson apologized to the mayor of Texas to say, I'm sorry that we exported Ebola. And I said on Al Jazeera, actually, I think we should be apologizing to her for not actually building up West Africa's public health infrastructure much earlier. Because when I look at the parallels of the re-emergence of polio in Syria after 18 years and the rise of Ebola, they are both contingent upon these very fragile public health systems. In West Africa, there have been decades of civil war and conflict and neglect of the public health system. In Syria, it's been actively destroyed by the current regime. And chlorine, our fundamental tool of public health to safeguard our water, is actually withheld, and worse still, it's even used as a weapon of mass destruction in chemical attacks. So the other piece of the human rights issue is the gender element, where the people on the front line often are the caretakers, are the women, the nurses, the midwives, the carers at home who cook, the mums who cook the food, those who prepare the bed. So there's always a gender dimension where women are more vulnerable, and so are children. Children are more vulnerable by nature of their age, and also because in these particular countries, Africa, Haiti, and now also in Syria, they have a host of other comorbidities, which make them much more vulnerable. We're not seeing very many international die from Ebola at the moment, because we are much stronger. And then, finally, I think we still have this second-class response to what we consider the world's second-class citizens, which sort of compounds the way that the nature of these epidemics, and which is another illustration of how political these pathogens are. And I just want to finish by saying, as a doctor, as somebody who works in public health and believes in it, I'm a critical care pediatrician. Never thought I would be in public health. It was so unsexy, but it's so important. And it's very clear with the rising tide of infectious disease that we really need to pay attention and get a handle on these in order to be able to address them very well, because we are absolutely dependent on our public health structure. And these are very political pathogens. Polio did not reappear in Iraq during the 8 years of war there. So we can't simply blame it on things like war. It reappeared because of the government lack of responsibility, the withholding of childhood vaccinations, as I've said, the political preferencing of public health. Thank you.
Well, what I wanted to speak about briefly is something that I think each of the other speakers, and Sonia included, touched on very nicely in their presentations, and that's the human dimension, the human element to emerging diseases, to outbreaks. And where we're going when we look into the future, we have a lot we can learn from cholera as a historical lesson. One of the most important things to know about infectious disease outbreaks, and particularly pandemics, is that by and large the majority of them are caused by us, by human activities. And when you look at infectious diseases, and I tend to work with viruses that tend to jump from animal reservoirs into people. So when you think about SARS, if you remember that from 2003, or Ebola, or avian influenza, what all of these have in common is that outbreaks are triggered by human activities, things such as deforestation or agricultural expansion, things that bring us and our livestock into closer contact with wild animal populations that tend to be the original sources of many of these pathogens. But what really relates cholera to many of the outbreaks we're starting to see recently, and what we will continue to see in the future, is connectivity, globalization. The world has become truly a very small place. With air travel, we can be anywhere around the world within 24 hours, and we tend to bring our pathogens with us. And so listening to the presentation on cholera, I'm reminded of how this was a bacterial pathogen that was endemic to South Asia, that spread to Europe and Canada via travel, and then through trade, people coming down waterways into New York and bringing cholera with them, and then it spread there. And it's the same thing with so many of these pathogens. outbreaks happen all over the world all the time, but what turns them from outbreaks into pandemics tends to be global travel and the way in which we're connected. So if you remember SARS from 2002, this was a viral pathogen that emerged in live animal markets in southern China. The natural reservoir for SARS coronavirus are bats, and bats are brought from the wild into live animal markets for consumption, very commonly eaten. So these bats are brought into an urban center mixed with many other animals of different species and basically handled and butchered by people as part of an everyday practice. And this is just an example, but this is how a bat virus gets into an urban center in Guangzhou. The virus jumps from bats into people and causes a localized outbreak of a respiratory disease. But it was really from there that it spread from Guangdong province to Hong Kong nearby, and from there, through air travel, people getting infected, traveling to 26 different countries around the world, where 8,000 people were infected with SARS. And so this is about our connectivity. Likewise, we're experiencing a relative of SARS right now in the Arabian Peninsula called Middle East Respiratory Syndrome, which was really just discovered about 2 years ago as a severe respiratory disease in Saudi Arabia. And it turns out it's very closely related to SARS, and it causes a respiratory disease that's infectious from person to person. And when it was discovered that it was related to SARS, we all went, oh my God, here's another pandemic starting to emerge in the Middle East. And it turns out that it's not quite as contagious as SARS is, but what's interesting is what appears now to be driving the spread of Middle East respiratory syndrome is actually the fact that it comes from camels. Not originally, like SARS, it's a bat virus, but at some point it jumped into camels, and now it appears that through camel trade, the importation of camels from North Africa into the Middle East, camels are bringing what is a pretty mild viral agent for camels into more contact with people, and when it gets into people, it causes a severe disease. And so it's our movement, not only of us, but of animals as well, that tends to spread these pathogens around the world. And connectivity has had a lot to do with the current Ebola outbreak in West Africa. We've had Ebola outbreaks since 1976 that we've been aware of, and probably well before that. We believe Ebola comes from fruit bats, so another bat-borne viral agent. And typically how it gets into people is either through butchering of bats or of other wild animals that have been infected with Ebola and coming into contact with bodily fluids. So there are spillover events like this that happen in Central Africa, and typically, historically, most of the Ebola outbreaks have been in the Congo-Gabon region. The difference is, in the past, that many of these have happened in isolated villages, where you'd have an outbreak of maybe 10 or 30 people, and because of the remote location of the village and the lack of connectivity from one village to any other, the outbreak would be naturally contained. What public health infrastructure there was, local clinics would become aware of these outbreaks and through experience would be able to handle them by isolating patients, and people would die, but eventually would be contained. In West Africa, there's so much more connectivity between the area where Ebola spilled over in Gekido, which is a densely populated area that has connection to many other villages as well as roads to Conakry, the capital of Guinea. And so this is an outbreak that happened in a small village where people were easily able to move from village to village and into a capital city, an urban center with millions of people. And that's really what accounts for the size and scale of this outbreak. And of course, air travel then, not surprisingly, has brought cases to Spain and to the United States, and we'll probably see Ebola spread to other countries. So when we think about the future of emerging diseases, of infectious diseases, I should say, it's going to have a lot to do with our own actions and activities. And we should expect that the more globalized we become and the more connected we become, the more likely we'll see outbreaks of diseases that start in some faraway place and end up here in America, which is exactly why public health becomes so important and why we need to care about what happens in parts of the world that are vulnerable to emerging diseases and that are vulnerable, and we need to focus resources on building up public health infrastructure because eventually we're connected to all these places too. So to me, that's really what links cholera to many of the outbreaks we're seeing is how closely connected we are in this world. And we're going to continue to see more and more outbreaks that spread around the world more easily. So I'll end there.
Thank you, John. If I could close by actually trying to address your comment about the role of the media, including our premier global newspaper here in New York, the New York Times. to get a report from CDC that said there may be no cases in January, or there may be 1.4 million, a remarkably uninformative mortality weekly report. But to have the New York Times report that as 1.4 million cases expected for Ebola in 42 font is an absolute disservice to the American population, I believe, in communicating true risk. And I think our mainstream media, frankly, in its desire to sell newspapers and sensationalize things, misleads the American population, as we've seen with the Maine bicyclists and the Talus episode and whatnot. Which is why places like the Pulitzer Center for Crisis Reporting are absolutely essential to do high quality, rigorous, evidence-driven, scientific reporting to support people like Sonia in her projects and others is, I think, a remarkably important piece in a moment in time where good quality journalism is very hard to support in this country. So I wanted to close by thanking the Pulitzer Center and the New York Academy for hosting this, because I think your point is right. We need events like this. We need to do the public education. We need to work to improve the quality of the risk assessment and push our political leaders to respond appropriately. Thank you very much for an interesting meeting.